DNA's podcast series, Let's Talk About Kidneys, provides education dedicated to exploring the journey of those living with chronic kidney disease. We're here to inspire meaningful conversations and to help people living with CKD gain a better understanding of their disease. Today's Let's Talk About Kidneys podcast topic is pregnancy and kidney disease, what to expect. If you have kidney disease and are wanting to start a family, you may have questions or concerns. Dr. Cindy Corpier joins us today on Let's Talk About Kidneys to share some helpful insights about how kidney health intersects with pregnancy and family planning. Dr. Cindy Corpier joined Dallas Nephrology over 25 years ago and is board certified in internal medicine and nephrology. She currently provides care for kidney patients at our Dallas North location. She also manages the care of patients with CKD that are either planning to start a family or are pregnant. Welcome to today's podcast. Let's talk about kidneys, Dr. Corpier. How are you?
I'm wonderful today. Thank you,
Good.
Tiffany.
We're so excited to have you join us again. You bring such invaluable sight to any topic that we present, but I know that pregnancy and CKD is something that you manage a lot of patients with, so we're going to just jump right into some questions, okay?
Great.
So Dr. Corpier, let's start with the baseline information. What is chronic kidney disease?
So chronic kidney disease is an umbrella term, Tiffany, that means that you have a problem with your kidneys, either the anatomy of the kidneys or the functioning of the kidneys. And everybody's lumped into that one general term of chronic kidney disease, but there are many, many, many conditions that are covered in all of that. When we talk about kidney function, I would just say, just to back up even a little bit more and just say, human beings are biological machines, and that means that we require energy and we create waste, and we create different kinds of waste in our body continuously, all day, every day. And so this is all going to be recognizable to everyone because we all know we exhale carbon dioxide, that's one form of waste. We all have a colon and we know about the solid waste that's created there and expelled from our bodies. And we have two other internal organs that are very important in managing it, the chemical waste, and that's the liver, and you don't even know what it's doing until it's gone, and the kidneys that create urine. And well, what is urine? Urine is sterile water with chemical waste dissolved in it. So what the liver can't deal with, the kidneys are dealing with.
How can someone with CKD prepare for pregnancy?
So there are a few things in no particular order, but a woman who knows that she has chronic kidney disease is most of the time going to be seeing a nephrologist anyway, and if a women of childbearing age, we've already discussed birth control, for example, and conception and what their plans are. And when they decide to move forward with a pregnancy, then there are several things to address. The first is really, well, what is your level of kidney function? And basically, the better kidney function you have, regardless of the disease, the lower risk you have with pregnancy. Then we go to their medications. And there are certain medications that we prescribe to women, to all of our patients, but in this case to women, that are for blood pressure control and maybe for their kidney disease, if they have a transplant, if they have lupus, etc. And certain of those medications cannot be given during pregnancy. Some of them we can give, some of them we have to stop months in advance and convert to something else. Some of them we say, the minute you have a positive pregnancy test, stop this, let us know, and we change medications. So those are two of the big things.
Okay. And so you mentioned briefly high blood pressure and the medication that women or anyone that has kidney disease are prescribed. So if a woman has been diagnosed with high blood pressure, how does that affect the kidneys and also the pregnancy?
So just to also kind of generally talk about hypertension in pregnancy, you have women who go into pregnancy who have normal blood pressure, and they develop pregnancy related hypertension and new onset hypertension during the pregnancy, and some of those will be easily managed and their blood pressure goes down after the pregnancy, but some percentage of those women will have a worsening and can get a condition called preeclampsia. Then you have the other group of women who have chronic hypertension. These are women who are already taking blood pressure medications. They know they have high blood pressure, and so going into the pregnancy, that's when we look at their medications and say, and all their medications, but also specifically here their blood pressure medicines, and say, okay, which are pregnancy safe? There's an awful lot known about what medications can be safely used during pregnancy, and there are multiple blood pressure medicines that we can use during pregnancy, and there are a few that we absolutely don't use. Okay. And one of the common groups are what are called ACE inhibitors or ARB drugs. Those are medicines like lisinopril or ramipril, also losartan or valsartan, Benicar, which is olmesartan. Medicines like those that we use quite frequently in treating kidney disease, but those absolutely cannot be used in pregnancy.
Okay, that's good that you were able to provide the listeners some specific examples of those medications that will be discontinued once they are diagnosed with not only with kidney disease but also become pregnant. And so can you talk about how CKD impacts pregnancy overall? Just kind of paint that picture, because you have people that are watching or listening that have CKD and interested in getting pregnant. So how do those two kind of intersect?
Essentially, the better kidney function you have, regardless of the cause, that there's whatever the problem may be. Let's say you were born with one kidney, for example. That's a common congenital anomaly, that people are born with one kidney. They may have perfectly fine kidney function. And so somebody in that situation that has normal kidney function, like has 90% or 85% of normal kidney function, they're relatively low risk for losing kidney function with a pregnancy. Now, as you go down and women get into the 50%, 40%, 20% levels of kidney function, the lower their function, the higher the risk that they can lose kidney function, either temporarily or permanently. They're also at higher risk for much worsening of their blood pressure, of preeclampsia, and potentially strokes or cardiac heart conditions during the pregnancy. So that's really the concern as kidney function goes down.
Okay. And are women with CKD or women who have had a kidney transplant still able to have a healthy pregnancy?
Absolutely. They can have a full-term pregnancy, because that's always the goal. That's where we have to start. A couple of things. Though these women are all considered to be high risk, they're all considered to be high-risk pregnancies and should be managed by high-risk OB and see maternal fetal medicine during their, fairly early in their pregnancies. Nevertheless, they can have full-term pregnancies and can deliver vaginally, can deliver by C-section if necessary. And so, yes, they can have a healthy baby, and they can maintain kidney function. But this has to be managed individually. Right. And so one of the things I say is, or that we know, is we really need to sort of set expectations for women. Like, this can happen, your blood pressure might go up, and then we'll do this. The urine protein, which you're used to following, that might go up, and we'll manage it this way. If you're a patient with lupus, we know that lupus can flare. Well, how can we prevent that? And how do we manage that going through the pregnancy? And what if you have a flare? And how will we treat it? Or how can it be treated? And I think that it's very important for women to know that all these things I'm talking about can generally be treated, and that they can, have
A healthy pregnancy.
have their pregnancy. And really, we are with the OB doctors in the sense we all want healthy mama, healthy baby, full-term pregnancy if we can get there.
Okay. And so even though it's a very small percentage here, I still think it's a good topic to discuss. A small percentage of women that are on dialysis and are of childbearing age, how does that affect pregnancy? I know that can get complicated, but to those that are watching or listening and are part of that percentage, can you discuss how that affects pregnancy?
Sure, that is a vastly different situation, and that is much less common than women who have better kidney function, because we know that loss of kidney function impacts fertility, and so fertility goes down in women who have renal failure to the point that they're on dialysis, and even before that. So, but it's not 100% necessarily, and so women can get pregnant while they're on dialysis. If they do, the management is very different. They generally, people who are on hemodialysis go for 3 treatments a week. Unless they're at home, they may do 5 a week. If you're pregnant, then we have to intensify dialysis, which means more time, more days of the week. And so generally we would dialyze 6 days a week if a woman's pregnant to try to get them to the pregnancy. We're looking to bring their laboratory tests under far better control, because essentially what you're trying to do is have the chemical makeup in your body to be as close to normal as we can get it for the growth of the baby and for the maintenance of the placenta. And then we have to be very careful about blood pressure and about fluid. So yeah, that is a small number. There's some data that seems to indicate that it's happening more often. I can honestly say I've dealt with it very rarely, because it really is uncommon. But part of the reason it's uncommon is because it's uncommon to have women of childbearing age with kidney failure as well. So
how do post-transplant medications affect a woman that is pregnant or becomes pregnant?
So in the transplant situation, it shouldn't be said to a woman that, oh, you can't have a baby. That's way old news. Okay, we've known for a long time that women could carry pregnancies, have healthy babies, even though they have a kidney transplant. And what we generally recommend is that they not proceed with pregnancy for the first year or 2 years. We used to always say 2 years. Now people tend to say sometimes more 1 year. And women who are in their 30s, can really feel some great urgency about this, which is understandable if you want to have a family. And so we have to plan for it. And the planning means that we will have to make adjustments in medications in advance and give them time to essentially fully eliminate certain medicines from their bodies, because there are medicines that can, again, we're back to the groups of pregnancy safe medicines versus not pregnancy safe medicines. And so we have to change medicines, and then we have to monitor and make sure the patient is stable, and that their kidney function is stable as we can get it. Everything. They're not having urinary tract infections, because those can have an adverse impact on pregnancy. But yes, they can certainly have had babies, many babies. Right. We love babies.
Yes, so, we love the babies. Yeah,
we love babies.
And so, are there any other pre-existing conditions that will make a difference in a woman's pregnancy? I know we talked about high blood pressure, so that's a pre-existing condition, but any others?
Yeah, high blood pressure or hypertension is probably the most common that we deal with. And then there's some then diabetes is another one, which can certainly have an impact on pregnancy. Then one of the ones in the kidney world specifically is lupus. systemic lupus erythematosus, or SLE. People know it by these names. And generally, again, that's kind of like a transplant in the sense that ideally we're planning,
Right.
and we've got you stable and you are in remission with your disease, and have your medications adjusted before going forward with becoming pregnant. It's well known that lupus patients can have flares of their disease brought on by pregnancy. Now, there are recommendations that they continue certain medicines. Again, to speak to preeclampsia, which is this condition of very severe hypertension that can happen in any pregnant woman, and usually happens later in pregnancy, but that can be prevented by, for example, taking aspirin daily, starting at about 12 weeks, between 12 and 16 weeks. Daily aspirin can help prevent that condition in a lupus patient or other patient. Specifically in lupus patients, they can continue certain of their medicines. They can continue Plaquenil or hydroxychloroquine, and that's recommended for them. Some of them have to be on other blood thinners. So they can be very complicated. But again, they too can have, term or very close to term pregnancies, and maintain kidney function and have a healthy baby. I mean, we're not saying they should not have babies, but ideally, you're in remission, and we can do all this as safely as possible. Because really, that's what we're trying to do.
Yeah. Not
Not trying to ever discourage people from having a family, but just try to make it, safe. Because these moms are, they're at high risk. So.
Okay. And so, speaking of moms and following the treatment plans, can you give us some examples or talk about some patients that you have had in the past that are pregnant and have had their babies? Or I know you have a couple that are going to be having some at the end of this year. So can you just give us some of those examples to let the audience know that it's happening and it's available for them to start a family?
Yeah, one of my patients that I started following very early in my time at DNA when I worked in Irving. I was a nurse, and she had a condition called IgA nephropathy, but she had very good kidney function. So I met her when she was single. We went through met the boyfriend, married the boyfriend, and then started wanting to have a family. Yeah. And so we've been through it all, and now the older of the two children is in college and the other one's getting close to graduating. I have a whole bunch of picture Christmas cards in my office of the kids as they're growing up and have grown up, and I've seen them, throughout. She had 2 healthy babies. Now, she did have a change in her urine protein. We did have to adjust blood pressure medicines. There were some things, but 20 some years into it, she's still got normal kidney function. So that's a very fortunate situation. Yes. And she's got these 2 healthy kids. This year, 2025, I've had the unusual situation of having 3 women who were pregnant. One of them was in full remission with the disease that she had for some years, and I will see next month, and I believe she's delivered, but I haven't heard from her. But she had a very ideal situation: good blood pressure, normal urine protein, stable kidney function that was almost normal. So that was kind of the best picture you could have. Right. Then I have a couple of other ones. I have one who is going to deliver in December, and we're looking forward to that. So far, she's done well. Her situation is because people are like, well, why do these people have kidney disease? Like, these young women have kidney disease. Well, in the case of the first 2 women I've discussed, both of them, these are conditions that happen, and we don't exactly know why. They kind of come out of nowhere. They're what are called primary kidney diseases that impact the kidneys, and they just show up. And those first two women. This other lady who's going to have her baby in December, she has a totally different situation. She was born, earlier I said part of chronic kidney disease by definition is anatomically abnormal kidneys. She was born with abnormal anatomy. This happens sometimes, right? That everything doesn't develop exactly right. And that's what happened to her. And she developed problems with protein in her urine and such as a child and then as an adolescent and et cetera. And so when it comes to the time where she's married and now she wants to have a family, she's got about 50% of normal kidney function and normal blood pressure going into it. Her weight was normal. And so she's having, so far she's had, we don't even have her on blood pressure medicine. Like it's been, and she's having a good pregnancy so far, and we'll hopefully, healthy baby before Christmas.
All right.
I have another patient who's a more complicated patient who is, a young woman of also in her early 30s who really wants to have a family, and her condition's lupus, and her condition's more complicated and has protein in the urine and, has a more complex condition as most women with lupus and pregnancy do. So, and she's not quite as far along, so her due date's a little bit later, but again, so far so good, and we're very, very hopeful for her.
All right. So we want to thank you so much, Dr. Corpier, for your participation today. You certainly have, those of us here in the studio, you have enhanced our knowledge, and as far as the viewers, their patients, their families, just getting a better understanding of how kidney disease and pregnancy can kind of intersect, but you just gave some great examples of how it is babies on the way with CKD. So thank you again for joining us, and we appreciate your time and your consistently just providing us education.
Thanks very much.
All right. Thank you for joining us today on Let's Talk About Kidneys. To learn more, call 214-358-2300 for more information or to schedule a consultation. Thank you for joining us today. For information about Dallas Nephrology Associates, please visit our website at dneph.com. If you found our information helpful, feel free to share it with others who may also be affected by chronic kidney disease.
Dallas Nephrology Associates' DNA podcast series, Let's Talk About Kidneys, is provided for general information purposes only and does not replace the need to talk with a healthcare professional about your unique situation, care, and options. Our goal is to provide you with as much information as possible so you can be as informed as possible. Reference to any specific product, service, entity, or organization does not constitute an endorsement or recommendation by DNA. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of them or any entity or organization they represent. The views and opinions expressed by DNA employees, contractors, or guests are their own and do not necessarily reflect the views of DNA or any of its representatives. Some of the resources identified in the podcast are links to other websites. These other websites may have differing privacy policies from those of DNA. Please be aware that the internet sites available through these links and the material that you may find there are not under the control of DNA. DNA shall have no responsibility for the accuracy, legality, or content of the external site or subsequent links. Contact the external site for answers to questions regarding its content. The resources included or referenced in the podcast and on the website are provided simply as a service. DNA does not recommend, approve, or endorse any of the content on the linked sites. The content provided on this website and in the podcast is not medical advice and should not be used to evaluate, diagnose, treat, or correct any medical condition. The content is solely intended to educate users regarding chronic kidney disease, end-stage renal disease, ESRD, end-stage kidney disease, ESKD, and related conditions, and ESRD, ESKD treatment options. None of the information provided on this website or referenced in the podcast is substitute for contacting a healthcare professional.